Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who is our guest today?
Today we have Melissa Wachterman, who is at the Dana-Farber Cancer Institute and VA Boston and the Brigham Women's Hospital, where she is a palliative medicine clinician and researcher. Welcome to the Jerry Pal Podcast, Melissa.
Great. Thanks for inviting me.
We start off with every podcast with a song request. Do you have a song request for Alex?
Yeah. Running Down a Dream by the recently deceased Tom Petty.
Mm-hmm. And you saw him in concert a little bit before he died, isn't that right?
I did. He was like rocking out. I'm not quite sure. I mean, I guess I did hear what happened. We won't go into that. But yeah, no, it was like end of July. He was totally rocking out and then saw the obituary like a month later. So
it's very sudden. Yeah. All right, here we go. It was a beautiful day. The sun beat down. I had the radio on. I was driving. The trees flew by. Me and Dale was singing a little runaway. I was flying, yeah, running down a dream that never would come to me. Working on a mystery, going wherever it leads, running down a dream.
Nice.
Wow. Channeling the great. Impressive.
Tom Petty's fun.
So we're going to be talking about your article about the association between hospice lengths of stay, healthcare utilization, and Medicare costs at the end of life among patients receiving maintenance hemodialysis that was published in JAMA IM this last month. Maybe before we go into the details of the article, can you tell us how you got interested in the subject?
So I've been studying patients with end-stage renal disease for a while now, and one of the things that's been sort of loud and clear in this population is that they are sort of really sick, and they really, their quality of life near the end of life isn't great. So I feel like there's a lot of room for us to improve things. And so that another thing that we found is that they don't use hospice a lot. And, I think that what wasn't as clear was, okay, so those that actually do get to hospice, sort of what are the differences? What are things like for them? And the main driver question that I was really interested in is how long are they in hospice?
Yeah. So do you have any personal, clinical experiences with this issue that you could in an anonymized fashion relate to our audience so that it's HIPAA compliant?
Sure. Yeah. So another piece that I have been studying is decision making about dialysis initiation. And so I sort of pulling into a patient, I'm actually on wearing the hat of a medicine attending. I do palliative care attending, but also sort of medicine attending. And I was wearing the medicine attending hat, and we had a patient who was a relatively young, functional guy, veteran, who actually had advanced liver disease, really advanced liver disease, to the point that he had hepatorenal syndrome from his end-stage liver disease. But it was sort of pretty sudden onset, as I say. He was a sort of functional guy up until that point, or relatively so. And so it became clear that time was short. Clearly, he had hepatorenal syndrome, and but that dialysis probably would buy him a little more time at the point in which we were meeting him in the hospital. And he was lived at a distance and really, really wanted to get closer to home. Like he was like 6 or 7 hours from home. And so then the question came up, okay, so are we going to do, dialysis or not? And, it is one of these things, just thinking about decision making when you're wearing the attending hat, compared to the palliative care attending hat, it can feel kind of different in terms of it. Basically, I felt like in line with golden values, and the palliative care doctors were obviously doing more in-depth analysis, that doing dialysis probably did make sense for him with the goal of getting home. So then it became, okay, well, how are we going to help support this guy who has a very poor prognosis? And to me, it was just a no-brainer. Like, we send this guy with hospice, potentially may need inpatient hospice, but he'll be so much closer to home. But then there hits the policy barrier that as long as he's going to get dialysis, he can't get hospice. And so it actually was, while I was writing this paper, was when it sort of came up. But yeah.
So maybe a little bit of background, just because this gets into a complicated, thorny issue around dialysis and hospice. Like, what can be done in hospice with dialysis?
Right. So if your hospice diagnosis is end-stage renal disease, you cannot get hospice until you stop dialysis.
And that's not because Medicare says you can't do it, just that Medicare won't fund or pay for dialysis anymore. So
right.
It's the hospice's responsibility, and hospices would go broke if they were paying for dialysis in their patients. Is that right?
Yes. That is basically right. I mean, I think that there are some people that just, do you qualify for this diagnosis of end-stage renal disease? Even just a qualifying for hospice under that Medicare diagnosis, I think it can be a little fudgy in terms of, because there's always two issues, like, do you qualify for, do you have a hospice diagnosis, and then exactly what will the hospice what will Medicare cover?
Do you mean that from a prognostic standpoint, like figuring out somebody who's on maintenance dialysis? Are they hospice eligible with a prognosis of less than 6 months?
Well, right. So that's where I think the data is very clear, that there are a lot of patients on dialysis who have a prognosis of less than 6 months, hands down, no question. So that's where I feel that there's a little bit of a bias. I think just that people, and I think this gets at some other issues around just people on dialysis, doctors, like, oh, well, this is dialysis, like that. Take care of my kidneys, I'm good to go. And I think that some other work that we've done in the past, that, patients often have a much more optimistic picture of prognosis than they actually do. So I do think that it's not, well, as long as you're on dialysis, you're going to live more than 6 months. So we can, nothing is perfect, but there are sort of prognostic models out there. Like, we can, do as good a job as we can in many non-cancer conditions with prognostication. So it's not just, well, we can't find these people. We can identify the people who are at high risk for dying in 6 months.
So, Melissa, in that case that you described, is it possible that a hospice qualifying diagnosis might have been the patient's liver disease and liver failure?
Yes, and so this does come up, and this is where I feel like, right, I mean, so the way we talked about it being, when it's your hospice diagnosis, you can't get dialysis, and Medicare won't pay for dialysis and hospice together. But yes, if you qualify under another diagnosis, for example, right, he had end-stage liver disease. It's actually a really good point.
But I actually think in that case, because the dialysis is related to hepatorenal syndrome, which is related to his liver disease, he would not qualify.
Interesting.
He would actually have, and I wouldn't say he won't qualify. He would have to
pay. The hospice would have to pay for it.
Yeah, hospice would have to pay for it because it's related to the terminal illness.
It's related enough. Oh, so if your patient had developed, had pre-existing, if a patient, this would be a completely different patient, had pre-existing need for dialysis due to poorly controlled diabetes, and then developed a cancer that was fatal. Then that situation, that patient could qualify for hospice under the cancer diagnosis while still receiving dialysis, paid for separately by Medicare for the long-standing end-stage renal disease?
Yes, that is exactly right. That's exactly right. And it's the example I often use is the metastatic cancer one. And so it just seems very arbitrary in terms of, it just seems like it feels very arbitrary that in that case, you could continue to get the dialysis because it's not related to your hospice diagnosis. I do think that, and Eric, I think that's great the way the hepatorenal syndrome one really sort of susses out the issues between issue versus a qualification issue. And you're exactly right. The patient would not qualify. Would qualify, but would not. But the hospice would bear the brunt of paying for the dialysis, which, as some sort of opened with, like, hospice is just they can't stomach that cost with the amount that Medicare pays for sort of per diem hospice.
So tell us what you did in this study, like succinctly, understanding that many of our listeners are clinicians and not researchers.
Yep. So essentially, what we were interested in looking at was what proportion we use United States renal data system, which essentially includes all patients who have received, who have end-stage renal disease, whether they had a transplant or been on any form of dialysis. And so we looked at this cohort of decedents. So these are all patients who had died. And we looked back at what proportion of them had received hospice, and then amongst those that had received hospice, how long had they been in hospice. And essentially, we found that only 20% of these patients were receiving hospice services when they died, and 42% of them were in hospice for 3 days or less, which, comparing to sort of overall Medicare populations, is about twice the proportion of patients who have these really, really short stays, and they're also about half as likely to be in hospice at all.
So there are kind of two main headlines. Wait, if I could just reiterate the two main sort of findings here. The first one is that, what is it, like 1 in 5, 20 what percent?
20%. Mm-hmm.
Yes, about 1 in 5 patients who are on dialysis enrolled in hospice before death. So just 1 in 5.
Which is a
significant
increase from 2000.
Yep. So because we did look at some trends over time, and sort of similar to what's been going on in the general Medicare populations, there's been huge growth for both patients of all different diseases in the use of hospice. What hasn't changed, both for the overall Medicare population and certainly for our population, is there's been kind of this no change in the sort of high proportion of patients who are in hospice for a really short time.
And but I think that 1 in 5 may be an important number too, because to me that seems low, and I wonder what overall rates of hospice are, like for overall Medicare population, people who die, who are Medicare eligible or receiving Medicare, and then 2, what the proportions are for people with other serious conditions like cancer. Like, how many people with cancer in Medicare receive hospice prior to death?
Yep. So the 2014 data, 48% of the Medicare population received hospice prior to death.
So about half. So you're talking about 1 in 5 versus half. And these people...
1 in 5 versus 1 in half, yep.
Yeah, that's a huge difference, considering that these people are on dialysis. These are seriously ill individuals. So that means that there's some sort of barrier there. And there may be many factors in that barrier, but one of them is likely this issue about Medicare, not providing a mechanism that's feasible for funding both hospice and dialysis at the same time.
That's right. I think it's important, the point you make there is, so I think that the policy is just one factor. I think there's a lot of reasons why patients with end-stage renal disease are less likely to use hospice than patients with other diagnoses. So I don't know that if we, all of a sudden change the policy, that all of a sudden we'd have comparable numbers or comparable proportion of patients with end-stage renal disease.
So what do you think the other factors are?
So I think there's a number of factors. I think patients often with end-stage renal disease don't have a sense of how sick they are. So in other research that we've done, we asked, what do you think the chances are you'll be alive in a year? And the majority of them said, over 90%. So I think that there's this perception that, that I'm on dialysis. I have, there's a machine that takes care of my kidneys. That's my issue. So I think I'm good to go. And I think in part that is, as clinicians, I think we are not having conversations about prognosis. I think that, yeah.
Are the nephrologists having those conversations?
Right. They're not. So in that same study, we found that asking patients, how often has your doctor talked to you about this? Like less than 5% of patients had conversations about sort of their individual prognosis. Their doctor had not shared sort of an estimate of prognosis with them. And nephrologists are pretty open about this as well, that they aren't talking about it. And interestingly as well, when you ask them, if a family asked you for an estimate for themselves, nephrologists don't feel comfortable sharing.
I want to go back to the other key finding from your paper, which is that when only 1 in 5 use hospice, but then when they did use hospice, they tended, a substantial group of them used hospice for a very short period of time.
Nearly half, 41%.
41% for less than 3 days or less?
That's right. That's right.
So that that probably also is driven, I think you're assuming here, by people stopping dialysis very close to death, then starting on the hospice benefit. Is that the kind of driver, or what are the other factors that lead to that?
I think that's right. And I think it's both. I think it's both policy and also sort of models of care. I mean, I think patients that are on dialysis, they get wrapped up in, they have very high treatment intensity when we look at other measures like to the intensive care unit. They're a group that has really high healthcare utilization. And I think that my sense is, not being a nephrologist, but having spent some time, with colleagues who are nephrologists and spending time in dialysis units, it's like there's kind of this culture that's, very, very, very aggressive. And then it's kind of until there's kind of something else, a medical crisis that almost like they're dying from something else, at that point is kind of the first time that things change in terms of treatment intensity.
Well, I think the other thing is, especially if first of all, you did not include those people who started dialysis in the hospital in the ICU for a couple of days and stopped them, right?
Right. These were all patients who had made it into the USRDS. And in order to be in that registry, you have to have received dialysis in an outpatient setting.
Okay. So the other question is, like, for these people who've been in maintenance dialysis in the outpatient setting, one of the things that we've seen here is that the dialysis unit becomes their family, becomes their social network in a way that they don't view dialysis as sometimes a medical intervention, but as, it's a thing that I come to on Monday, Wednesdays, and Fridays, and I meet my dialysis nurses and I talk to the other dialysis patients. So I just wonder how much is that playing a role?
I think we often think of initiating dialysis as like the worst thing in the world for somebody's quality of life. But as you sort of allude to, there's definitely stories, patients I've seen who are socially isolated and they start dialysis, and it's actually sort of a form of socialization, a community. So I think that sometimes, there's that. I don't know, kind of stopping there. But
that's one of the factors. But here's another suggestion, Melissa, and maybe I'm interested in your thoughts on whether this is a factor. Is, the decision to initiate dialysis for some patients may be a marker of underlying values and preferences, that a dialysis is, a life-sustaining intervention. And if they've selected that once, might they be selecting that at multiple stages along the line? And so might just by looking at people who are receiving dialysis, examining a group of people who have a underlying values and preferences aligned with receiving life-sustaining treatment that may, Eric's looking at me like, where are you going with
No,
this?
I like this. It's like a marker of the goals or their goals and values.
Right, marker of our goals and values that may not align with hospice for some of those folks in some situations, right?
Yeah, I think, in the United States, the vast majority of people do start dialysis. So I don't think that we are selecting for like, these are the kinds of people who, would do, absolutely anything to stay alive.
And that's because we don't have a good alternative at this time of like, what is supportive care without dialysis? That's
right. I do think that is true. And there's a really good people working on, building models of care. I do think that even with a, solid supportive care in place, there's going to be a really large group of people who their goals and values, they want to take a crack at dialysis, and they are also frail and likely to die in 6 months, and that it's not always inconsistent to start dialysis.
Okay, I have a follow-up. Here's another idea. Maybe because dialysis is pretty much the only option, we don't have a good supportive care system in place for people who have end-stage renal disease or whatever we're calling it now, chronic kidney disease, that by starting dialysis and offering it as the only option, we train people that when you have an organ that is failing, we have a life-sustaining procedure for it. And we train people, in a sense, to sort of indoctrinate them into this, there is a problem, we can fix it with our technology sort of mindset, so that we are transferring some of those goals and values of our technology-driven Western system to those patients.
I think there's definitely some truth to that. I do think that there can be sort of an on-off switch, like, okay, you've bought into this, you kind of have bought into it all. When you think about something like code status and, dialysis, there's a qualitative study that, a very illustrative quote about a dialysis nurse who was like, there should be no such thing as, DNR, DNI, in a dialysis unit. Like, they've kind of, they've signed up for wanting to live. So, they can't make choice. I can't remember exactly the quote, but essentially.
It's like the post-op setting and the covenant that surgeons feel that patients go into.
Right. Gretchen Schwarzy wrote about this. Yeah, the covenant with between surgeons and patients.
Yeah, you've elected the surgery. You're going to elect really a lot of aggressive interventions post-surgery too, even though that's not discussed.
Right. But I don't think the answer is just, because I think we're kind of doing the same thing if we tell people, okay, if you don't want those things, then you don't want dialysis, you want conservative care, supportive care, because I do think there's going to be people in that zone where they want to, do at least a trial of dialysis, but if things do not go, sort of hoping for the best, but not sort of getting on the train to, ride on through aggressive care, till the last stop if things don't go well.
What else did you find in your paper?
So we also looked at the Medicare costs for patients with different lengths of stay in hospice, and found that with longer lengths of stay in hospice, Medicare costs were lower, and that these really short stays of 3 days or less were actually more expensive than not having hospice at all.
Oh, wow.
So that was another thing.
So having a length of stay in hospice less than 3 days actually cost Medicare more money than if they didn't elect hospice at all.
That's right.
So what's the answer here? What do we do with this?
Yeah. So I think that we need to come up with more flexible models of care. And this isn't for patients with end-stage renal disease. And we've spoken about some of that in terms of having, a better sort of supportive care track available. But I don't think that's the end. I think we also need to have more flexible models of care for patients who are going to do dialysis, or at least a trial of dialysis. What does a time-limited trial look like? It's thrown around a lot in nephrology community. It's sort of, well, time-limited trials, but what are those, and what are the benchmarks that we're using in terms of circling back to whether continuing dialysis makes sense? And then for those that are going to continue on with dialysis, how do we think about transitions when things aren't going as well, and kind of breaking down this sort of on-off switch around interventions. I do think that we hope that it would inform a policy discussion about the potential idea of concurrent care, of not making these patients make the terrible choice between continuing dialysis and getting access to what we know is a package of services with hospice that has a lot of benefit for patient families in terms of improving quality of life.
So do you think that needs to be done through hospice, or are there other mechanisms like palliative care, consult, inpatient, outpatient, potentially in this population, outpatient integrated in dialysis clinics? Do you think that's a potential solution?
Absolutely. No, palliative care is absolutely critical in its ability to meet these patients, upstream of these sort of, but end of life. Palliative care is available to patients with advanced serious illness at all stages of disease, and I think that early integration of palliative care is a big piece of this.
So you actually did a paper about this in JAMA IM, looking at palliative care, whether or not in different diseases people received palliative care in veteran populations, and then associated that with things like quality of end of life care. Do you remember that? Can you tell us a little bit more?
I do remember.
Just making sure.
So
Alex one time wrote a paper and then took a board's exam question.
And missed his question.
And got the question wrong, and they cited his paper.
I don't have enough papers to be able to have that happen to me.
Sorry, Alex, for outing you.
Essentially, in that paper, we looked at patients with different serious illnesses and looked at the rates of palliative care consultation and other sort of markers of high and low quality of care. This VA study, the Bereaved Families Survey, is a really rich study because it asks family members about how would you rate the overall care that your loved one received. They ask about a lot of other questions too, but that particular question, we saw that patients with sort of organ failure both had much lower rates of palliative care consultation and also lower rates of their family members reporting the care was excellent. And when you looked at that association between diagnosis and rated quality of care, once you sort of factored in palliative care consultation, the differences were gone. So sort of making the argument that palliative care consultation can really improve quality of end-of-life care.
That's great. Well, before we go...
So I was just going to say on the palliative care front, I feel like a really important message for clinicians is while there is this barrier to accessing hospice, that barrier does not exist for palliative care. And so it's definitely, if our paper does nothing else than to raise awareness about sort of this patient population, I do think that palliative care involvement is critical, and that there is not a policy barrier to that. That said, I do think that there is added benefit of having hospice services as things start to get worse, but not necessarily having to wait till they stop dialysis, not a service that's available to people literally in the last days of life. So I do think the added benefit being that access 24 hours a day to a nurse, the bereavement services. Like, there are things that hospice is sort of added benefit beyond just palliative care.
Well, I really want to thank you for joining us on
Thank you,
this
Melissa.
podcast.
Appreciate
It's
joining
great
us. This is
chatting
fun.
with you. Maybe to end us, Alex, can you give us a little bit more?
A little bit
of that
more of
song?
Running Down a Dream by Tom Petty.
Yeah.
It felt so good, like anything was possible. I hit cruise control and rubbed my eyes. The last 3 days, the rain was unstoppable. It was always cold, no sunshine. Yeah, running down a dream that never would come to me. Working on a mystery, going wherever it leads. Running down a dream.
Nice.
So, anything else you want to say, Melissa?
So I do feel like for this population, essentially, we're asking them to make a decision to stop dialysis in order to get hospice. We think about sort of cancer patients as a population. We're often talking about hospice. And essentially, as people die within days to a week after stopping dialysis, it would be like saying that patients with cancer can't get hospice until they stop taking any oral fluid.
Uh-huh.
I think that that it's kind of stark in terms of, well, we're not going to sort of give these services until it reaches a certain sort of endpoint when, of course, all hospice days, could be, we know overall median length of stay in hospice is relatively short. Everyone could probably benefit from, a bit longer stays. But I do think that it really, for this particular population, we're really limiting it to sort of the final days of life, which don't think we, I don't know. It's just, again.
Yeah, I mean, I think the hard part is it's not about, nobody's saying they can't do this intervention. It's like the chemotherapy question where it's about financing. Who needs to pay for this intervention? Which is really the limiting thing. It makes it in all practical ways. It says people can't continue dialysis if it's their terminal illness or related to their terminal illness.
Right. The financing serves as the barrier.
Yeah. The finance serves as the barrier, but nobody says, because we do a lot of disease-modifying therapies in hospice, like everything that we do for CHF in hospice, like we're continuing their diuretics. And it's this old traditional way of thinking, breaking down the body into organs instead of a holistic approach to the person. That doesn't make a lot of sense. And that's probably the thing that we should challenge. It's more about the needs of the person rather than a need of an organ.
Totally agree. Thank you, guys. This is really fun.
Thank you, Melissa. Appreciate you joining us.
And
all right.
And thank you to all the Jerry Pal listeners out there. We look forward to talking with you next week.